Doctors, and welcome to this edition of Invisalign Explorer to all Latin America. I'm Dr. Ayana Martinez, the expert in clinical education for the region. Today we have the pleasure of sharing with Dr. Hector Garcia La Torre, who is a surgeon from the University of Guadalajara. We're with him in Mexico, and he's also a member of the Association of Orthodontics and also a great friend. Doctor, good evening.
Diana,
hello, good evening, everyone. Diana, good evening, and thank you for the amazing welcome remarks. To me, it's a pleasure to be here with all of you doctors sharing this Invisalign Explorer It will be 2 amazing 2 hours of clinical cases of pure knowledge that I am very anxious and looking forward to share with you. So let's start. The theme of today is treatment of class 3 cases. And what I would like to share with you is the experience that we are having in our clinic with this population that it's more and more broad in terms of case 3. The most common cases are normally class 2, class 1 in case of crowding, but class 3 have lower percentage, but they are more complex treatments. So this is why today we are going to see different ways of treating with aligners and with Invisalign these cases that can be something very challenging. And before starting with the theory, I would like to just mention that I live here in Mexico City. Our office is here in Mexico City. I've been here for 10 years, sharing with the people of Mexico City, these amazing people. I am in love with the city, and really the city has given me so much that I cannot give it back to them, give back to them. But I like to share my techniques, but today I also would like to share about my office. This is my clinic where I work. And we have moved here like a year ago, right in the beginning of last year, in the beginning of the pandemic. In March, we moved to this corner, and we needed to make or give it a personal touch. So this is why I decided to give it a new facade. So I would like to share with you also my facets as an architect. So I really took the pen and the paper and the eraser, and I started to draw to make a redesign of this clinic, give it what we want to share in it. And because we bring the best of technology, which is what Invisalign is all about. And so this is the result. This is the change. So we're very happy for being able to give it its new facet to this clinic, to change it. And this is the clinic of 2021. We are still remodeling, we're making changes, but this is going to be the final design. So you can see the before and after, and I can tell you that this was the design that I did, and using all of the support of an architect that works with me, a great friend of mine, that worked with me, a great friend of mine, but I'm very happy with the result. So you can see my gifts as an architect. Anyway, now let's start talking about the issue of class 3. As I said, class 3 is a very reduced population, something like 10%, which is the number corresponding to these cases in consultation. And a class 3 is really, it has interesting features to treat when we compare with class 2 and class 1 in terms of crowding, because of all the features that are presented in the gum. So there are some features that I would like to share with you before diving deep into the subject. How to correct class 3? What options do I have? The first one is extraction. But normally, when we have a compensation or scholastic movement of the jaw, we're thinking of removing or pulling the lower molar. So our view as orthodontics, within the new trends, the new way of treating the patients, the way to go is by erasing from the map, but we don't want that to be the way to go. So extractions is one of the options that we have to treat class 3. Another one is orthodontic surgery. That also depends on the decision if the person has any mandibular or maxillar problem. But after all, this kind of surgery is an important element within the skeletal corrections in terms of orthodontics. And the third one, the third option that also gives us an option is that of orthodontics camouflage. And in there, we can find corrections with elastics. We can also find TADS. And also one very important one that has become the most important to me, which is sequential distalization. If we can think about sequential distalization, we could say that it's like the patent of the aligners, because in fact, it has been a movement of sequential distalization with fixed apparatus could be very difficult. So we need to anchor ourselves with apparatus of temporal anchoring, or maybe make a series of irregular movements that could cause side effects. But if we do sequential distalization on the teeth, something with the aligners could be sensitive, and it's a way of correcting strongly and with safety class 3 movements. So we have to use the check, the clean check. About 2 or 3 years ago, the aligners were something new on the market, and we remember that these aligners have been around for about 3 or 4 years. We didn't have all the cases that we have today. So really, people didn't trust in a system in which in this kind of aligners, because they had the other kind of system that offered them great results. But nowadays, these aligners are doing large, and they will probably remain for a long time. That's why we need to adapt ourselves, and we need to adapt our consultations. We need to start to think about mechanics with aligners as the basic part of our repertoire in our treatments. And well, how they're more similar with, how they're more predictable with aligners in class 3. We need to take into account a few criteria. The first one is that I can correct up to 4 millimeters of distalization with aligners without using any kind of extra support. But a line could give you a more discrete number from 2 to 3, but I can tell you empirically that if we do it in a protocolized fashion, 4 millimeters is a number that is reachable in terms of correction. Of course, the age of the patient must be taken into account. Remember that among patients, we have the little patients, we have the growth factor, and it's more difficult to treat than a person that is not going to be growing. And of course, this growth factor, we need to take into account if this growth is in our favor or against us. And in class 3, in growth, they usually go against you. We need to remember that the jaw stops developing later. So this is an important factor. Another important factor is to know if our class 3 has any kind of, if it doesn't have skeletal components. Another important factor that maybe sometimes you don't take into account is that the system has a superficial of gripping or of grooving that is bigger, so that increases the sensitivity. I have a bigger grip ability if my crown is bigger than if compared with a small one. So Even though it may not seem as an important factor, it is an important that we need to take into account for a correction of a greater degree where we're going to use different greater mechanics. And also you need to remember that we have a different classification in terms of jaw. And this classification of mesh, I would like to share with you because in fact, it's not the same as correcting a class 1, a class 2, and a class 3, because in addition of other factors such as the vertical, there are other, when we are going to move the teeth, we need to consider the cortical or the density of the bone and its corticalities. So we need to take into account that the density of the jaw is smaller. So that allows us to make some movements that if we do in the jaw, the bones will be more dense. So the factors for movements, especially when considered in a movement of sequential distalization and also in a movement of closure of spaces, we need to take that into account. Now, within camouflage, we have sequential distalization. And remember that this is a kind of aligners that is one that we have on the market for class 3. And then all of a sudden, we are in consultation. We have an adult patient of about 30 to 35 years of age who presents these clinical conditions in which we have a compensation of the lower incisives that are inclined, and the upper incisives that even though they're not inclined, they had a little inclination. But we also have a movement of 3 millimeters of distalization that we are able to get. And this is what we have to set as a goal. Well, this patient came with the idea of putting the aligners. It's a surgeon who really likes the idea of aesthetics and wants that his treatment to be aesthetics. And what he wanted was a treatment that wouldn't use those brackets within the possibilities that we gave, because he was consulting with other orthodontics that offered them. But one of the options was to remove the premolar on the lower part, and the other option was orthodontic surgery. And all of the doctors mentioned that they didn't recommend using aligners to treat the case. And I said, I don't know if we are actually in a phase of weird, and I'm talking about ourselves, to trust in a system such as Invisalign, but I think that something has to change. So as I said, it's up to 4 millimeters of distalization that it can do without using any support technique. So this patient, we can correct in a period, we could correct in a very short period of time, just with the aligners. And what happens is, this is not the case at the end. This is just the first phase in which the additional, the first phase we are going to send, this is the first phase, we're still going to send them extra aligners, but I don't have to worry about the vertical issue, but we just made a correction of a class 3 in just 1 year. And well, so as a summary, we can have a predictability that is very broad if we distalize sequentially with the Invisalign to up to 4 millimeters. We need to bear that in mind. And how do we do that? Well, you have to plan. This is a very important issue that I would like to share with you. While I am distalizing, I am going to use one of the laws of Newton, which is action and reaction. So if you pay attention, you see that these teeth were retro-inclined when we began the first phase. As I said, this took 1 year with weekly change of aligners, and we can see cross distalization, and we can see the sequence while it happens, and we see this effect of placement of the lower incisives, which is going to help us a lot. Only elastics and sequential distalization. And obviously, this sequential distalization is one that is accelerated because while the molars don't come to their final point, I start to move the first molars, and while the first molars starts to take their final place, that are going to go like halfway, then this is a positioning and correction of positioning. And this is the clean check, visualizing the inclination, that at the end we are going to have a great result. The spaces that we saw in the previous zone are spaces that are already been put in the correct place. So as I said, it's 44 aligners, basically 1 year, changing every week. So it was about 11 months in which we cut the first phase, and now we're going to wait the second phase. And well, to give you an example that is more concise, we're going to start with the first clinical case, which is the sequential distalization. And I like this case because it's a case that really compromises the participation of the patient. This is a patient that definitely didn't want to do the treatment. She was very much afraid because of the surgery. She didn't want to do surgery, and in class 3 is okay, is normal to have surgery. If you can see, we have an overbite on of the jaw, and the lateral pictures we can see that we have 4 millimeters here of distalization that is necessary, a discrepancy of class 3. And we can also see that we see this drop in, we have a crossed bite here. This gives me the idea that if I already have a premolar in a position that is very close to a class 3, well, why complicate my life? So I just extract the lower teeth, right? But the patient didn't like the extractions, so we had to use a second option, which is a little illogical, but the second option was to remove the lower molars and do the distalization. So she didn't want to do the extractions of the front teeth, but she wanted to all of the teeth, because we know that the third molars are usually removed anyway. But she wanted to keep her teeth normal until the end of her life. So what we did was basically do this distalization to 3 to 4 millimeters with this premolar, which is basically or very close to a functional class 3. But sometimes we know that even though are complicated cases, we can give them the opportunity to try to correct them and favor the requests of our patients. And well, obviously, we decided to remove the third molars, only the lower ones, for obvious reasons. But these are the radiographies that we have, the x-rays that we took from the beginning. And as you can see, because it's a class 3, we have a skeletal situation, and we have class 3 that is more marked, more visible on the left side. And of course, we have to make a small twist of the jaw while we are making this distalization. And normally we are projecting the incisives forward, and also to give a little bit of line to these smiles, we're making this arrangement. This is what, you know, that I never put the attachments, but obviously for the requirements of the patient, in this case, we put these as few as possible, and they stayed as little as possible in the mouth. So these are the images. As you can see, the distalization is great, and there is a lot of movement of distalization. And we can see that immediately as we start the treatment, we did the extraction of the third molars, and I would like you to focus on the left side of the patient, because this is the one where we got to do more sequential distalization. And yes, we're going from a class 3 functional to an occlusion of class 1 in 48 active aligners. And this is the distal occlusion. This is distalization which was slower than the ones before, for a matter of safety, I would say, because sometimes we ensure that the cases have a certain level of speed, and if it's important to take that into account also for an amount of time that the client will have to use the aligners, or it depends on the speed as well as the use. And this is after the 48 aligners, which is the first phase of the treatment. We can see that it's a class 3 functional. We can see that the premolar is already in 86, but it's very close to class 1. It's also almost a class 3, but it's not much that we have to correct. And on the right side, it's more vertical and inclination case to get this class 1 correctly. As a matter of fact, I would think that we have a small class 2 in the side of the mouth, and this is also, you see in the discrepancy of the median line. As you can see, the lines are deviated, and I have to use the lower arcade on the left. And on the right side, we can talk about a small class 2. So I have to make a twist of the jaw to make the correction of this problem. And then we're going to have a second phase where we're going to have approximately 18 active aligners. These 18 active aligners are going to help us to correct the lines as well as the class 2 and the some of the class 3. And we are applying some of the sequential distalization, but a little bit faster. Now it's more possible to ensure that the client uses the elastics. So I can request the the technicians, to accelerate the speed, because it will be more foreseeable because of the help of the client. And as you can see on the right side, it became a class 2. This help us to make all the twists that I mentioned before. So here you can see that I want to give more focus on the lower incisive. This is something that we need to revise, that is very important when you do the clean check. The lower incisives, they seem to be very much retro inclined, and this is very important to me, that now I do it differently. I changed this because definitely the clean check gives us a reading that is a little bit different from the reality in terms of torque. So we that have the clean check seems the inclination seems to be okay, but in fact the teeth are a little bit retro inclined. This is why you have to use Invisalign. This is a recommendation of mine. And as we have a class 2 and a class 3, so now we just distalize only one side. And the other side we are correcting with a little bit of correction and elastics, with inclination and elastics. To have our final result after 17 months of treatment with weekly changes, we're talking about 67 active aligners, and with the concluded cases, this is the final case. And definitely the patient was very happy. And there are some erosions that you can see here.
Sin embargo,
and
final, la verdad es que estuvo muy contenta.
The final result made her feel very happy, and she decided to keep her natural teeth. And I think that it's a very beautiful result, even though there are some areas of abrasion that seem to be areas a little bit dark. But the client is very happy because there was a very good change in her teeth, and it's a lot more functional. And this is the before and after. As I said, the crowns were a little bit smaller, and we come from this
3 a 4 milímetros de distalización.
3 to 4 millimeters of distalization to this.
Inclusive,
all right. As a matter of fact,
la distalización
if we look, the distalization of the premolars is a little bit bigger, and I would have to take all of this zone to here, because we were talking about 4 millimeters of distalization. And sometimes we can find cases in which it's better to correct the inclination or vice versa. And I mean that maybe it's more of a class K9 3 molar. So this is something that we need to take into account, especially the vertical issue. So this is the final result, and after 17 months. Before and after, we had a change. This is the smile before and after, where she didn't have the teeth correctly. Also, she had a crossed bite. This is the profile. You can see there is more volume to the upper part. So now her teeth are correctly positioned. And here we have the smile. And finally, the result of a correct occlusion. I really like to share this with you, because we can see the difference between the position of the torques of all the premolars, because this is a position of progressive torque, negative towards the posterior in the upper arcade. And I invite you to revise this with your final work with the aligners compared with brackets, and you're going to see that the posterior torque is a lot more continued, a lot more symmetrical. Of course, if we work in the clean check when compared with brackets, you have to remember that the brackets are too big, and so this game sometimes allow us to have a more inclined teeth than one teeth here and a molar there. So now, talking about the combination of this sequential distalization plus intrusion, now I'm going to share a case that is a very recent case. It's a case of a patient that orthodontics patient, And well, she has an harmonic smile. It's a negative smile. It's a negative, I mean, it's a smile that she doesn't like it. But the story behind this smile is a little bit tactic because we can see that the bite is absolutely irregular and makes us, I mean, we can see that the results will be good, but not only the results, the best part is the functional change. And I talk to you as a functional orthodontics. Remember that we must have not only the functional face, which is indispensable, but also the aesthetics. So if we are functional orthodontics, we are probably going to this people are not going to like us so much. And if we are aesthetics, then we are going to have a problem with the patient because we could cause a lot of problems. So we need to have this balance. And you can see that this patient doesn't have much to say. We're talking about a class 3 canine, but a class 2, a molar. And why? Because we lost premolars. These premolars were removed to correct a problem of occlusion at the time, in that moment of her life. But how do I explain to this patient that in order to be able to get an occlusion stable and functional, it is very possible that, very likely that we have to remove lower teeth, or another is that it takes time to correct, correcting tooth by tooth, correcting all the inclinations that she has in their teeth. And the vertical issue, because an open bite happens because the context does not allow for that. So this is a challenging case. It's a case that maybe is even more challenging than the first one, or maybe it's okay, but are different cases. This case has a vertical inclination, and well, obviously we know that these third molars will go, but if the patient gives the opportunity to the whole treatment, it's very important that for this kind of case, we remove the third molars. Well, I'm going to go back a little bit because I would like to add to it. If you see, we have the central incisives. We don't have so much surface in the bones. We have here the crests, and we can see that they're very gummy, and so something that we have to treat very carefully. Now this is the side, and this is the most important to this patient is to explain that their bite is very wrong, even though their teeth is not so bad. And this patient, her sister also had a class 3 problem, but it was different. It was class 3 that was different, and it was because of a matter of aesthetics. She didn't know that it was bad. So the work is to begin to work both vertically as well as sagittally to be able to save as much time as possible. Remember that the expansion will go with the sagittal, and it can also come with the vertical, but you're going to see better on this side because you're doing an intrusion of both areas while we digitalize sequentially the left and the right side on the lower side, and we intrude. At the end, there will be a change, and you remember that we need to learn how to work with the biomechanics and the aligners. The diagnosis is the same, but the way of treating is different, and it has to be, we have to learn to create protocol of our cases if we want to be successful. It's not to accept what the technician sends and approve the case. We have to remember that the clean check takes time and we need to dedicate, and that is what our success depends upon. In this occasion, for aesthetics matter, we decided to put the posterior centrals because I will require extrusion, and when the client asks you for aesthetics, so we eliminate this and we go to Palatine. And if you can see that the elastics we are using are class 3 elastics, because that gives us correction, not only transversely, but also this distal rotation of the first molars. So with these elastics, we are expanding, and we are expanding while we digitalize, and at the same time, we are so you have to think how you are going to use these elastics. This is a way. Basically, we have many ways to do it. So think about how we are going to do it. And this is the first phase of the aligners, where practically we have the sagittal correction in the canines, like I mentioned before. Sometimes the class K9 doesn't have the same discrepancy. In this case, class 3, because it's a class 2 functional, but I want to move the molar, but it's a class 3 that is not so marked in the area of the canine. So we can see, when we analyze, we can see that the distal curve, if I correct vertically, I may not correct the sagittal part because they work hand in hand. And so we go to a second phase of aligners, that in this case is where we do the correction. And we also, once again, make a sagittal correction. We are going to see more easily here. Now we are compiling the extrusion of premolars with a small extrusion of the molars, but we're also combining that with the distalization. And basically, this is going to correct the problem. Remember that even though we may want to use a lot of things, I try to use only in those cases that are interactive. Obviously, in cases that are very complex, in which are necessary, but so long as you have these 4 millimeters of correction, you can use them and they work perfectly.
Ahí estamos.
Here we are. So we finished the treatment in 20 months. This was a case that was a little bit longer than the first one. The first one was 17. This one we finished in 20 months with weekly changes, and definitely the bite was approached in an adequate fashion. And at the end, we have an occlusion that is a lot more integrated than we had before. We changed the class 3 and we included this class 2 with the adequate inclination of these first molars, especially this extra inclination that we need in a class 2 functional, so that it fits perfectly between the premolar 34, 35 and this extra tip of the molar. And well, as I said, obviously we this case, I think, took about 10, 12 days after the finish of the treatment. In this case, we had a big change in the patient, and she was very happy with the treatment. We have the before and after. And obviously, we can integrate the bite. The crowns are too big, and I really like that when the patient allows me to give them this height, to the crowns, because to me, a big clinical crown with an adequate proportion is a lot more aesthetics than a small crown. Before and after. Pay attention to the number of aligners. We had 79 before and after. And on this patient, she also brought her sister and her cousin, and her brother had a crowding that was bigger than her, and finished the case in less than a year. So sometimes she asks why it took her longer. Maybe because the case was more problematic. Sometimes the patient comes because of a crowding, and they think that the crowding is the reason for the treatment. And so we have to explain to them that that's not the way the cookie crumbles. We have the before and after, and we can see the anatomy of the molars. It gives us this possibility, even though of the wear, it gives us this possibility. And this is what I really like, because we're able to get with the projection of the clean check. And here we can see the interesting thing, which is the facial change. This is the before and after. We also expanded this smile. And we made the crowns a little bit smaller. In some cases, we improved the aesthetics of the smile. Before, it was a little bit shyer, I would say. And we wanted to make it broader. I prefer to have a small part here. And I consider that is a beautiful aesthetics. And probably it's been like this for 3 years. And this is the way I've seen this for the last 3 years, and maybe I changed my mind. But anyway, I like what is in fashion, as they say. So what is in fashion, it's probably beautiful, right? And this big teeth is the fashion now. So I think that now it has more harmony between the past and the present, right? And this is the final result. Well, after the correction with sequential distalization, we have the option of camouflage. And camouflage we can do with the simulation of elastics. And this doesn't represent the fact of moving teeth by teeth, but it represents removing with the elastics themselves. And in order to take into account correcting a class 3 with elastics, my recommendation is, I believe that if the patient is on an adequate age, so check their age, and we have a favorable growth, then maybe you could be a class 3. But class 3, pay attention, because class 3 growth could be a problem, as I mentioned in the beginning. Because the maxillar keeps growing even after the person stops growing, and it depends a lot. It varies from patient to patient, where we're talking about 16 to 18 and sometimes 21 years of age, and it also depends on the gender. So my recommendation and this is an empirical question, is that I trusted in correcting distalization with elastics of a maximum of 2 millimeters. Literature talks about 5 to 6 millimeters, but I call you, pay attention. We need to pay attention to articulations and other issues that I don't want to mention now, but this is why my recommendation is that you do a maximum of 2 millimeters of distalization with elastics. If I could tell you what I really considered, I would be talking about half a millimeter or 1 millimeter maximum when I am just using elastics as a simulation. Another important fact is the inclination of the crowns, because the crowns, they change a little bit. So my mechanic of class 3 is very sensitive. In a class 3, I don't move teeth by teeth, but the movement could be that of projection and movement of retraction on the lower. So projection upper, retraction lower. And this would be the final result. So imagine that a client comes to your office with these characteristics. A patient comes to your office. It's a patient who's 50 years old. Is a patient who comes with a recommendation from one of his friends, a referral from one of his friends, who, as a matter of fact, is a person who I know. And I said that to correct this problem, they told him that he needed to find somebody to correct this problem because he had a problem not only vertically but also sagittally and also transversally. So what I recommend is that surgery in this case should be done. But my question is, would you do surgically? Well, probably yes, probably no, probably you would, if you had the opportunity, you wouldn't do surgically, or maybe you would do surgery, which is the easy way. But you have to pay attention to the diagnosis and also take into account what is the position of the patient. And the position of the patient was, I don't want surgery. Can you help me without surgery? I said, well, let's try. So 8 months later, we are correcting everything which is sagittally. Of course, we still need to work on the vertical, but the crowns increased a little bit with resin because the patient likes that. But this is the result of the 33 aligners, right? And here, now I'm going to share with you, many of them are in this presentation. These are my tips. First one, this is a personalized digital system which allows us to make movements according to what I want. Here, we forget about philosophies and we forget about what people say and what a doctor said, and you start to see problems among doctors and orthodontics. But what I want to share with you is, let's just forget about everything that we have learned and all the evidence that we have from patients with brackets that do not adapt to some irregular anatomy that our patients have. So these tips is, let's do our clean check, which means if we have a discrepancy of 2 millimeters, well, we do a virtual occlusion because we're thinking that this centric retraction doesn't change so much. But think about a patient, for example, like this. If I wanted to do this more adequate positioning that gives me the opportunity to relax the patient, then I would do it this way. And this is why on the clean check, I will do it this way to make a correction that is more correctly and even more sensitive. So this is why we have 33 active aligners, and we use 3 aligners for the final correction and 3 more. So this is why we use 39 in total. But you can see that we are making an assemblage in the closest that we could. So we have a much more sensitive case that we were able to finish in 8 months. Now we're going to work the vertical part because the sagittal part doesn't work so much. And we already corrected the transversal part. Now we're just going to work on incisive torques and the inclination, and obviously the bite, because it was deep in the beginning of the treatment. So now we have a change, a big change in the posture of the patient. This is a patient that we worked in 8 months, but I want to share with you because it's something that really deserves that we take into account of what can be done in a system of aligners. Now, sequential distalization plus simulation with elastics could be a combination of both. So we remember the factors that I mentioned before. 1 millimeter, 2 millimeters maximums with elastics, and up to 4 millimeters sequential distalization. So let's see the third case, where we're going to talk about a class 3 case that can be treated only with the correction of simulation of elastics. This story is very peculiar because it's a patient that definitely, I mean, these are the best patients ever, because these patients are the ones that oblige you to make the case with aligners. And when this patient came to my office, I was in a phase of transition where probably I didn't want to let go of the brackets and leave them behind. So today I tell you that today I feel a lot better that the patients do the treatment with aligners, and if not, I motivate them to use them, because to me is better. I know that they are more sensitive. To me is more sensitive than to treat them with apparatus. So in this moment, I hadn't eliminated the fixed brackets. So this patient comes to me and says, "Doctor, I have a lot of issues, but there is one tooth that is in the lower part that is hurting my gum, and I want to correct the aesthetics, and I know that I have a bad bite. I need to correct this bite." In this moment, what really concerned me was the 25th and the 37 that was inside the bone. So let's see a little bit further on. And you have to make decisions to solve this kind of cases. So I talked to the buccomaxillofacial expert about extracting the 37. We're going to see a little bit further on. We had here an important issue because we have to remove the 38, and we also had to remove the 37 so that we could make a correction of 90 degree, the 25, and all of the crowding. So we talked to the patient, we talked about the timelines, and we decided to start to work the whole part except for the 38. And I said, "Doctor, let's correct the other ones and then we do the 38 afterwards." That's what she said. I said, to me, that was fascinating because it removed a big weight while I was making the correction of the others. Now for this, I also talked with the experts and said, I have a big rotation. I would like to start to work with a hybrid system. I need you to give me time to rotate your teeth, your premolars, while I am working on aligning your teeth. So with her, we did a clean check and a half. And what does that mean? That means we are working aligners on all of the segments in the lower part, and partially in the upper part that goes from the 17 until the 23. So this obviously gives me secondary effects, like we're going to have a premature contact to the 25, and this is obvious. Doesn't reach 23, so we're going to have this kind of discrepancy. So that means we are working the clean check divided only 19 aligners, in this case 19 aligners, but they're active, and we're talking about 5 months, and we thought that 5 months was enough, and well, we planned this way. We did a partial clean check, and you can see that I'm also doing a simulation of correction of elastics. Attention, this depends a lot on the patient. If the patient is not a good patient, you don't use that. But in this case, because it was approximately 2 millimeters, 2.5 millimeters, we decided to try, and we planned it this way. One simulation of correction of elastics, and here we have a small sequential distalization. This is why I mentioned that it was a combination, but in fact, it's more focused on the distalization. So in the first 19 aligners, this is what we got. You can see sagittally, we don't have a correction of class 3. It's very little in 5 months to make a correction like this with only 19 aligners. It's very little, but I cannot base on occlusion on the right side and a real malocclusion, because remember that I only have one point here, which is the point of contact of the teeth, where we start to have the fixed apparatus. But what do I have here? I already have the 25 that is absolutely out and aligned. So we start to work. To me, telling the patient, now this is the beginning of the treatment. The patient told me, but doctor, I am happy because of the results I have so far. So I told the patient that the first thing I want is to get rid of this premature contact and start working on the correction. Here we can see a correction with a simulation of elastics, and at the end there is a small jump or change of a bite, because I am working on this case. At this point, I wasn't so much in love. At that point, I wasn't so much in love with sequential distalization. Today, I would say that that's one of the best things. But pay attention to the result of the treatment. We continue with the simulation of the elastics, or the correction with elastics. So between the first, when we have the first phase finished, we have this result. The patient is very happy. I am happy because definitely I am erasing all the problems, and I start focusing on the lower side, because this is something that is inside my subconscious mind. But if you pay attention, we're going to start these third phases. Give me 1 second, please. I am going to activate this part. Just give me 1 second. This third phase I'm going to start. This is the second phase that I'm going to start with the premolar. That's important. So we continue. And now we're going to focus on finalizing the case. We're going to finish this case. Correction of posterior torque. definitely to be able to get the good placement, a little bit ostrigen so that this can be done perfectly, the settlement, and done. Finished, case finished. 18 months of treatment, 18 months, and weekly change of aligners. A very happy patient, and the orthodontics even happier because this was a case that really was led correctly, even though a little bit weird. But at the end, remember that it doesn't matter the way in orthodontics. If we have a good result, then we can say that it was successful. So this is the final result, the before and after, 1.5 years of treatment with weekly change. And here is the x-ray. The patient decided to leave things as they are with a promise that in the future we're going to change. How will I do it? Well, definitely I will do that with brackets. I'm going to put a micro implant. We are going to put a micro implant and we are going to obstruct so that we don't have to change everything afterwards. This is the strategy. We're able to change the incisives and improve the profile. She didn't like her lips because it was a little bit bony. So I gave the inclination to the incisives without removing the premolars. And if you look, we can see that there was a change, but we didn't change so much so that she wouldn't recognize herself. So we're able to get a very good result at the end. Before and after, 18 months of treatment, 67 aligners. This is the profile. It's a very beautiful profile. I like it. In fact, I also like the previous profile, but I also see that you can see that there was a little marcation. So we needed to work on that. The inclination of the incisives, it's obvious that we have a correction inclination, even though we can see a small projection of the incisives, and we can see that we are approximately integrated in the position of the mouth. So how we're doing? I hope that you are not so tired. I know that sometimes I get carried on sharing about cases. I think we have another half an hour, right? Yes. All right, great. So now we're going to focus on the class 3 corrections with extractions. Remember that in the beginning I said that the place is never out of the map. Whether it's extractions or surgeries, sometimes extractions can sound as something that is very positive for the patient. And this will be reflected in the facial aesthetics. So my recommendation for extractions is we have 6 to 7 millimeters predictable with extractions. This is, or in other words, a sagittal correction of 6 to 7 millimeters corrections. It's possible with an extraction. So we're talking about 6 to 7 millimeters of retraction can be more foreseeable in the treatment or predictable. Another important factor that I have mentioned throughout my whole presentation is the age of the patient. We need to remember, but especially in classes 3, where the patient normally, when they're very small, they have the growth factors. So we need to play with that. Something that is very important, that I think that is the most important part of these cases, is to plan our anchoring type. After protocol, the most important part is to always have a protocol. We want you to do your protocol to protocolize the movements because we want it, that brings us success. It's like having a guide before the test. If I'm going to have a test, but I have all the answers to the test, so that could help me a lot. So if I have all the answers to the exam, that means that I'm going to have a much better exam. Another important thing is to consider the use of elastics in class 3. Class 3, remember, everything is different. In class 3, the movements are more complex. And this is why we need to use auxiliaries that helps us. And among the auxiliaries, we have buttons and elastics. Another important tip is to retract the canines first. At least the retraction of canines has to be 1/3 of the closure space, at least. And if I'm going to do a reciprocal anchoring, it has to be reciprocal so that this process, the following process, which is to accelerate the clean check, is more foreseeable. And what do I mean by that? The more foreseeable is to bring the canine always to class 1 and then bring the segment, but this would take longer. And furthermore, what could happen is that the aesthetics would not be so adequate when we don't have much space for the client, the patient, and also could create a scar on the tissue. So the consideration for retraction, because when we do that retraction, that depends a lot on how much time you have to treat your patient. It varies a lot. And for example, in class 3 of crossed bite, I don't know if you can reach, if you are able to know what is the case of this patient. But anyway, this is an adult patient, about 40 years of age, where he made, we have a crossed bite, and this crossed bite is caused because of a collapse on the left side. And how does this collapse happen? What should I do then? How am I going to compensate that? I have a canine, but I don't have the laterals. I have the line. So how would I treat that? How would you treat that with brackets? How would you treat that with the aligners? This is a deviation of 3 millimeters, and it's important to correct it as much as possible. And when I see the lateral distal, I can see that we can see the canine. So automatically, in the moment where I have a class 1, a molar that is well settled, I am thinking that I have an imposter in the picture. And we have to get someone, and that will be the 34. And why do I do that? Because I need to open space for the implant, but with all of the implications that you have in the moment of putting an implant, and also in the future, sometimes remember that I talk to the patients to tell them what I would like to do, what I can do, what are the limits, and what is the success that we have to reach if we involve an expert. The patient usually helps me to make the decision, and that's very important to me. So we make the decision to make the camouflage and to remove 34. So we're talking about that we already have a candidate to replace the lateral, that is in this case is the canine, and then we are going to work this way. So This way, we have a very huge correction of 7 millimeters. Why? Because I have 7.5 of size of a premolar and a little bit more here. So 6 or 6.5 and a little bit more where it has to be very good. So we're talking about a correction of 7 millimeters. Here, I'm not going to talk about a sequential digitalization because I have a solid class 1, and I'm not going to sacrifice the solidity of this class 1 because to be able to make the correction of the previous zone. And well, this is after the last phase. Here, the treatment hasn't finished yet because the patient is still in process, but we can see that we have already converted the lateral canine. This part that you see here in this blood is because when we made the cut, and in this cut sometimes you have this kind of blood. The cuts are small, but there is a little blood. And of course, I cannot move the premolar. The canine was a lateral. And well, the only thing that I didn't get is the gum height. But we already have our solid class 1 that is perfect. We already our solid class 1 between quotes. And so what I was telling you is it will be a closure, and so that we can retract the canine and stop with the overbite. And this will give us a lot of move. And of course, if we do it this way, we accelerate the process because we're talking about 10 months. So we have to use elastics. So this is why it's very important considering them. And well, we pass from here to here. We have a correction of 7 millimeters in a record time. And we're talking about 1.5 years, I believe. Something like that. Yes, 18 months, correct. And if you notice with this patient, we had to work on the part of the medium line, the upper medium line, because it doesn't matter if it is deviated, but of course I'm trying to compensate it as much as possible. This is why I'm working with this proximal line on the right side while I seek to make the necessary correction. What I'm going to promise is aesthetics and symmetry. And if you notice, the patient has a very interesting symmetry, and we're talking about the canine already converted. However, there is the upper line that still needs to be aligned. We're going to put it on the right so that we can finish the case. The patient is very happy because we have a change of bite. The change of gummy smile to be completely corrected. But in this case, to finish, we still need, and this is in process of construction. We're talking about 3 or 4 months more of treatment so that we can finish it. And let's see another case of extraction. This case is a case that I really like because it's one that even though there were a lot of sacrifices, the advantages were much greater. This patient is a class 3, very marked one. So we're going to see that we have a problem of traumatism. And in addition, mandibular change. And if we think it's a very serious case, and if we add an inclination, then we have a very complicated case. But this kind of case, if you can notice, is very similar to the first to the first case, so we did sequential distalization, but it was not enough for me in this case, so I think that it's too much. Today, I would treat with distalization, and I'll explain why. In the moment that I was to remove premolar, I'm going to renegade 27 to be uncovered. But in this moment, I made a decision with the patient of removing the premolar, and I am not against doing it, but the decision that I made, I like it because you're going to see that there will be a change. But the deviation, the proclination of the big incisives, we have many crowns. Imagine working how terrible it would be to work a case like this with brackets, because you would have to be putting brackets here and crown, and then I have another crown as an implant. So if we look a little bit further, we're going to see that this case has everything that scares us: implant, crossed bite, deviated inclination, class 3, crowns. I mean, it's a bad case. So to have all of this means that we are thinking that an aligner would give us a good result in terms of correction. And yes, it did. They did. 3 to 4 millimeters of medium line, 3 to 4 millimeters of distalization. That, remember, the factor for sequential distalization are talking about 4 millimeters. So in this case, it comes into that criteria for distalization. And not so much extraction, because extractions are up to 7, but the extractions would be easy. It would be easy to solve the case with extractions. So we started with the retraction of the canines, and we are going to take this medium line to its position. It's a total of 40 aligners, active aligners. And we start to make the corrections. And it's interesting to see how the closure is done. Remember what I talked about, the management. When I do the anchoring, I'm going to use premolar, and then I see the sequence, and I'm also going to use a third of the canine. Attention. Tell the technician what you want, because the technician is going to close the space as he wants. So you have to protocolize and tell the technician, I want it like this, do it like this. And if they do it differently, you say, no, I don't want it, I want it this way, until you have the clean check as you wish. Because this is what your success is going to depend about. This is what I was mentioning. This is a closure that is a little bit more reciprocal, because I'm doing 4 and not 7 millimeters. And this is at the end of the first phase. And what happened here? Well, the matter of combination between the work that was done vertically, because this is an implant, and this is a crown that is very small. So I'm not waiting the crown to go up, but this level of bite has to do with this position. We were talking about this. So what happens is there's the medium line, if you notice, was 4 millimeters deviated to the right side, and now we are 2 millimeters deviated, which means that I have a very good patient. I don't have a class 3, but I have a class 2. So as I see these results, I need to talk to the patient, say, look, it's very good. So let's see more closely to see how these elastics goes and where your bite goes. This is also important to know where you go and how fast the change will happen and what's the intensity necessary to come to the right moment. It's not easy. And so this is why we're going to do a second phase. And in this phase, we're talking about 3 active aligners in which we're going to correct the problem that I still need to correct. And if you notice here, I am combining one simulation of elastics that you see at the end, that there are lips because I have a patient that is very good with elastics. It's a very disciplined patient, so I'm treating only the sagittal vertical issue, but I'm doing the simulation of elastics that, if you pay attention, you see that can be up to 2 millimeters. That's the recommendation. So I consider that these 2 millimeters I will get with these elastics, that it's not even 2 millimeters, it's 1.5 millimeters, as you can see, approximately. A little bit of compression of the lower arcade. Remember that we have an implant here on this side, so we have to work on it, and this is the final result. What I love in this case is because, even though it's not a perfect case, the occlusion on the right side is an occlusion that fascinates me. It's a functional class 3 that I really love. And on the right side, remember that we have the issue of the short clinical crown and the issue of the change of the implant crown, because this implant cannot be this crown. It has to be a bigger crown with a different torque, because it was positioned on the malocclusion at that time. So it's a small change that could be adjustments, right? 14 months of treatment, 55 aligners. And this is the result, the partial result. I really like the result. And here you can see the gum cut. We can see the beauty of the result that we're able to get. In these pictures, we don't see, but we can give more aesthetics to the smile, and if we can make a comparison, we have the before and after. 14 months of treatment with extractions. Now imagine to think in doing the extractions with a fixed apparatus. And I mean, on a personal note, it took me about 8 months using this apparatus. And from there, I started to closing spaces. Unless the patient has a lot of crowd, the space is not easy. But really, closure of space takes a lot more than 18 with the regular brackets. And this is why I like these aligners, because they take a lot shorter time. And many cases of extractions are selected to be used with this kind of aligners. And you can see the facial harmony. You can see how this face is a lot marked. And to me, this is magnificent, because it's an orthodontic patient because of the gum. But when you look at the final result, you can see that it was amazing, and maybe because of the bone, the result is not so huge, but this result here gives me a lot of pleasure, and I feel happy to share because the patient was very happy. All of the incisives are there. We did the problem of crowding, and everything that the patient wants in terms of objectives, we're able to get them. There was a change of profile. You can see how things change technically, and there was also a change of the smile just because of an inclination of the incisives and the harmonization of the malocclusion. And well, we're coming to the last phase of our cases. And we have cases of multifarial class 3 cases. Multifactorial class 3 cases are cases where we have all kinds of things and we don't know exactly where to start. Well, this case, I believe that is one of the most challenging cases that I have ever had. And this case, I really like to consider. It's a class 3, but because of the bite and also crowding, I mean, it's class, could be a class 2, could be a class 3. So the story you probably already know of this case, but I would like to share it with you. Anyway, the patient was treated in 8 months because he had an important event. He wanted to have a perfect smile and he wanted to be treated in 18 months, in 8 months and with Invisalign, please. I said, and what else do you want, as you say in Mexico, right? Because he wanted too many things in a very short time. But remember, you need to think on the mechanics of the aligners. If I see this, of course, I get a little bit scared. And yes, I know that it's going to take a lot of work. So why not classify in class 3? Because I definitely have a class 3 that is very marked. But I cannot classify as open bite. And I also classify as, I mean, I can classify as class 2, as class 3, as open bite, as crossed bite, as whatever the hell comes to mind, because I have so many problems. I mean, the clients have so many problems. And the problem is I have only 8 months to solve, and I'm not going to pull any teeth. So I need to do a very good planning and do a good protocol. And I create a protocol in 8 months. I said, I need 10 months. I cannot do it in 10 months. I know that if I do it in 10 months, I'm going to have everything ready. And I will probably have the result and correct everything sagittally and vertically. And I am talking about a patient who is 50 years old here, right? So he said, okay, we had a lot of work to do. We're going to have to find a way that this be done perfectly, but anyway, this was my problem. We have a complicated issue, and we start to work on the case. As I said, I asked for 10 months. It's 43 aligners. We're talking about 10 months. And this is what we planned for these 10 months. Let's look how I am playing with the vertical position. And furthermore, I project the lower incisives and I bring them here. I believe that this patient is going to help me in the correction with elastics. And let's see what happens after these 10 months. Here we put palatine lateral because we integrated. And you can see how, even though what matters is to arrive to the inferior, it is the inferior where we are protocolizing. Remember to protocolize, and you can see how there is a small discrepancy in the lower arcade, and this is symmetric. So first, I expand the 44, and once I expand the 44, now I adapt to be able to correct the crowding, right? So it is activated in different phases, and I protocolize. If I protocolize, I'm successful. So let's see 10 months. Well, 10 months, I have it ready. And definitely it's not the result that I want, but anyway, it's a good result. But this is not sufficient. This patient, I sat with him and I said, look, if I treat you now, I think that today it's very easy to treat your case. So why don't you give me opportunity to use more aligners and make you look better? He said, but how long? I said, let's just do it. And I asked time. I asked for 6 more months. And in 6 months, we reached to something more than perfect and something that is closer to what I really had in mind for this patient. And we are working and we are doing on the incisives and we are working on everything that I would work on a second phase. I am doing with this patient, and I already have the symmetry that I want. And 6 months later, I have this. And well, curiously, the story doesn't end there because the patient thought, well, I like the result. I want perfection. Can you do it? I said, well, perfection, I don't know, but I think that we can do it, make it look good. I said, how much? How much time? I said, I don't know. I said, let's work 5 more months. He said, oh, 5 months? No. I said, well, let's see. How long do you think it takes? I said, okay, let's work and see if we can get there. Let's do another round of aligners. The round of aligners took about 4 months. And we made this settlement and we did just the correction with the elastics. And to me, that was fantastic. And this also depends on one of the most important factors, which is that the patient be cooperative. We continue working on the torques, on the settlements, and the correction of the posteriors. We continue with the practice. We do the strippings. We don't have any problem with strippings because obviously I want to have stability until everybody is satisfied and he said, okay, your treatment finishes today, but 82 aligners is a long way, and that took that allowed us to reach 88%, 99% of the objectives that we had for this patient. And we come now to the before and after. And I don't know where to start, but we corrected the canines, we corrected the crowding, we corrected the canines that had no space. We were able to increase the zones of the upper arcades so that we could have room for the teeth. We also corrected the class 3 left and right. We also corrected the torque of the incisives, the vertical overbite and the open bite. We practically reached the 100% of the objectives, which made me and the client very happy. Of course, we still need aesthetic work, but you can see that there is still little to be improved, but it's not a big problem. The patient had a problem. We solved, and all of the zones improved in spite of the little verticalization. There will always be something that will not come out perfectly, and that's part of life. But along with in orthodontics, we are going to be able to have a great change. So this is the final result: 0 extraction. And this was very interesting. 21 months of treatment with weekly change, and these are difficult to move up. So this is a case that makes us very proud for the result, because aesthetically we also had a great result, and we take into account the crown that needed to change. This is the before and after. And if we look we called my friend. The client asks, "Doctor, the patient wants you to change this and that." So the patient, after the result, is very happy. The patient, of course, made a few jokes saying that he couldn't pay me. But then the patient said, he was making a joke saying that first he didn't want to do the treatment because he didn't have the payment. And another thing he said is, the second thing he said was, "What an amazing doctor you are," because he was so satisfied with the result. And I really like, even though he made a joke, I really like what he said, because the treatment was very good and he really liked the result. And I am very happy with the result. The patient is happy and everybody is happy. This is the before and after. If we look at this picture, we can see that technology has changed a lot. And today there is this, the Bluetooth has changed. You can see a change on the Bluetooth from the first to the second. He is a businessman and he doesn't remove his Bluetooth phone even to take pictures. But you can see that, well, the before and after shows great result. Before and after. Final result. Remember the photo. I would like to share this photo with you so you can see aesthetically what it looks like. Obviously, we're working in the other plastics aspects that gives us these results. And well, now let's go to the final part of the presentation. But before, I would like to tell doctors that we are working on our case class 2. The first tip that we have is inferior turbo bites. What is that? Well, something very simple. These turbo bites, they come as attachments in cases of class 3. What do I get with these turbo bites? Well, they can help me, for example, in a case like this where I have a crossed bite and I don't have the possibility of uncrossing the bite. This turbo bite could replace and allow me to work on distalization, because this gives me the anchoring and the movement, and I have a considerable difference that allows me to work sagittally more sensitively. Of course, it could be a little bit troublesome for the patient, but you have to explain that this is for a greater good. So this is one of the pearls that I would like to share with you. I hope that you remember the first one that I shared. And well, it's almost 2 hours of practice. So to say goodbye, I would like to share with you this picture that I really love, because this picture is part of our master aligners that we have annually. And in this edition of master's aligners that was in 2019, 2020, we had to remove it to 2021 because of the pandemic. And in these masters, we had a lot of friends and many personalities that participated. And to me, it is a great honor to have them with us. People from many countries, friends and colleagues. among them in this masters, in this group. Now there are many doctors in Invisalign. In fact, all of them that you see here are Invisalign doctors. So to me, this represents something that is very important to be able to share with all of you. And I feel very happy and being able to sow the seeds in so many people that will soon become part of the family is something that makes me very happy. In 2019, we had the master and great friend Flavio Escobar, who came to talk about Invisalign first. That was the first presentation of Invisalign first, and Flavio is one of the doctors with the greatest experience in this field. To me, it was an honor to be able to bring him here to Mexico to share all of his experience in 2021. It's no surprise that we're going to have Dr. Martin Perdenera, who's a great friend of mine. He came with us last year in the Invisalign B in Mexico City, and he is one of the most important doctors on the world level in orthodontics with Invisalign.
Bueno, las fechas se han desplazado.
Well, the dates have been postponed, but there are very few spots still left, but this is a training that is personalized. And in spite of the pandemic, I never surrendered to do it online, because I believe that the experience that we've had with the doctors is something that is unforgettable. For example, we had dinners together and we had so many good movements, and we had so many moments together. So it's 2 amazing days of pure knowledge and learning. It will be on the 17th and the 18th of September of 2021. And the subscriptions will be with Ana Ramos on this WhatsApp number that you on the screen. I hope you can join us, and it will be a great pleasure to have you with us. And well, I give you my social media. Thank you very much for being with me for these 2 hours. I'm very happy for being able to everything that Invisalign allows me to share. And now we're going to go to the Q&A. I think that Anna, I don't know if you have any questions to share with me. Sure, doctor, we have a lot of questions. But first, I would like to congratulate you for the presentation and also for the care in the finalization of our cases. We have a lot of questions, so let's start. And one of the first questions that we had is about the protocols. If you use any protocol in the cases of extractions of first molars, do you first uncross them? So clinically, how do you do that? Is that how do you present as a second tip? How could you talk a little bit about this thing? Well, today we work with one of the things that I mentioned with you, and turbo bites for the incisives, but my advice is to give you an opening in the moment of making the contacts and increase the verticality of the bite, then it opens up to 3 times more. So this allows us to make the this correction, this sagittal correction, which to facilitate in the mouth, but with the verticality that is allowed by the aligners, that allows us to have a good result. But if you consider that the contact will not be enough, then you could take a different strategy, but we don't think in that way. Great, doctor. Another question that is very common is regarding the time of the aligners. Do you have established protocol? Do you do it based on the patient? What would be your recommendation in that regard? Well, it is very important to mention that we, in the clinic, always use, and this is, we always use aligners. So if you don't use the aligners, we can try to we usually start to change every week, or sometimes it could change up to 10 days, but no more than 2 weeks. But yes, in fact, we ensure that the treatments have weekly change. This is the protocol that we try to apply. Perfect, doctor. We have another question regarding these patients that have short roots. What can you do not to aggravate those problems that in this case of patients, especially that have crossbite? Well, it's a good question. The first that I seek to do is to ensure to eliminate the trauma, the occlusal trauma along these teeth, because obviously this is that is causing the stripping or the wearing of the roots. And I try to avoid the problem of the movement of inclusion, because that is the most natural movement that you have. And this is what normally wears the tooth more, and along with a movement called torque. And to that, I would add that the speed of the movement of these teeth specifically has to be reduced, so that you don't have an abrasion of the teeth. Okay, doctor, we are going to have another question. We have so many questions, but because of time constraints, I would like to ask you, what do you do in terms of extractions? We talked about the movement of the thirds, but what would be the specific instructions? Do you have any instructions especially, or? Well, the thing is, it is difficult to answer this question because there aren't many there are so many doctors, and each doctor has every protocol. I like to work very closely with my technicians. I mentioned that you always implement the protocol and anchoring. In other words, in the protocol, I'm going to establish what is going to be my anchoring. So if I have to map out the way. If I'm going to do anchoring, then I bring the canine, and then I bring the anterior segment. And if I'm going to work with anchoring, then I bring 1/3 closing the spaces, and then posteriorly I bring all the others. And if suddenly I come across a deviation of the movement that I am looking for, I can put the elastics. This is exactly the second question, which has been very common. Let's take the fifth case that you presented. What kind of elastics do you use in general? Congratulations once again. Congratulations and greet from Uruguay, Chihuahua. But could you please talk a little bit about the protocol of elastics that you use, especially triangular elastics or elastic for distalization? Could you share with us a little bit? Well, normally when I'm going to apply distalization, I always think that the elastic that I'm going to apply has to be at least 50 grams. So we're talking about an elastic of 6 ounces, which is what's going to help us to do the distalization. But it also depends on the distance. If I have a case of extractions and the elastic could be 316. But if I have extractions, 6 ounces, if I don't have extractions, remember that the elastics work and I have to give the necessary power to it. So for example, if I have elastics that gives me 360 point in diameter, and if I stretch it 3 times, then this will give me a distance of application where I will have a point of application. So I like to be a little bit more cautious. If it's extractions, I put 16 or 516, depending on how is the power that I need on the elastic. Perfect, doctor. Now we have a very interesting question, and the final one, which is regarding the asymmetries. In class 1 and class 3, can I use elastic class 3 only with the aligners? How would you indicate that? Yeah, definitely, definitely. In fact, we do it continuously. If I have a class 1 in the aligners, I do not have to change. So I always have to work, because with the aligners, we don't have this problem with the inclination. So sagittally, don't worry, because we're going to play with the anchorings, as I have said, and you're going to keep on the other side the same anchoring that we have in class 1, but the class 3 is going to correct not only the elastic, but also the sequential distalization through extraction also. But I always seek to, if I see that I'm going to have a movement, then I always seek to compensate or intrude a little bit to avoid this, to produce this change. I think that we have time to make 2 more questions. In this case, what kind of retraction do you use? In case of extraction, if a patient doesn't want to, what retention do you recommend? I recommend all of the possible retentions, but pay attention. The most important retention is occlusion. And I've seen many cases in which if I have a class 1, if I have a patient in class 2, if the patient regresses to its control of 1 year or its review of 1 year or 6 months, I will always have a regression from class 1 to class 2. So the first recommendation that I'm going to give you is finish your case 1 perfectly, because this is the most important review. Now, aesthetics to me is very important. And also, I would give retainers, plastic retainers like Ribera, and I like these retainers because they're very beautiful, and you can see the difference between Ribera and other retainers, but this is what I would do. One fixed retention and plastic retainer. I don't use sequential. I don't like so much, but obviously everybody has their own interests and tastes for the cases. But like I said, all of our retainers are fixed and plastic. Perfect, doctor. The questions are very interesting. What kind of assemblage do you use in your cases? Do you work with RC? And if so, how do you do the scanning? Well, the question is interesting, and it's also a technical question. First, I'm going to explain something. Remember that in one of the cases, we sought to do centric retention. And the case of scanning was the class 3 of that gentleman that had a very marked teeth. But I'm not sure that, I think that the procedure to do this centric, I don't know if we are in the right way, but at least try to bring as much as possible. If you have a patient with a discrepancy, definitely you have to do your assemblage. If the discrepancy is greater than 2 millimeters, then we do it in, because depending on the situation, it doesn't require such a great change of treatment. But the question is interesting. It's a question that it's not easy to answer, because it has to do with a series of situations. Perfect, doctor. Congratulations from Argentina and Mexico. We have many doctors connected, so I would like to thank all of those who are in the South for their participation. We know it's a little bit late, but on behalf of all of the technical team, I would like to thank Dr. Hector for his amazing cases, and also for the possibility of presenting and sharing all of them with you, and also for this amazing presentation. Thank you very much for your warm words. Thank you for all the doctors. I hope to see you all in person. To me, it's always a pleasure to share. Thank you, Invisalign, for the invitation. Thank you, all the working team that is behind this presentation. And I just want to wish you all a wonderful night. Thank you. Let's continue taking care of ourselves, and have a good night, everyone. Thank you.